tonight we're very lucky, we've got our bariatric pharmacist, and it's always really interesting because lots of people think, oh, well, what about these meds? And it's not just about what you might be on right now. It might be for the rest of your life, because when you have bariatric surgery, it is for life. That anatomy is changed forevermore. So it's just good to have a bit of a basic understanding of what does that mean to the medications that you might be taking. So we're very lucky to have Raeesa tonight.
Everyone, so my name is Raeesa. I'm one of the pharmacists based at Salford Royal, and I specialise in surgery, which involves me getting into contact with patients undergoing bariatric surgery. And my role involves reconciling the medications and counselling on discharge and making sure that the medications prescribed are appropriate. In order for us to, so bariatric surgery changes many aspects. So in terms of the medications, that's going to change as well. So we need to try and kind of, I guess, get a brief understanding of what happens when you put medication in, what happens to the drug once you put it into the body. So if you have a look at this diagram here, as you can see, once you take the drug, the stomach is responsible for absorption, as is the small intestine. And how much, and then after, once it's absorbed, it's distributed into the bloodstream and it goes on to kind of go on to its desired effects. So how much reaches the systemic circulation, so how much reaches the blood circulation, is dependent on how much is absorbed. And the rate and extent of this, depends on how the medication breaks down, so how it disintegrates into the body, so how that solid tablet disintegrates, forms a dissolution and it diffuses into the bloodstream. So that's how it happens to a normal medication. Now, obviously, bariatric surgery results in anatomical changes to the GI tract, and so it's going to absorb some of them. It's going to affect the absorption of oral medications. If you do the next slide. So to, again, understand this a little bit better, it's dependent on the type of procedure that will affect the absorption. So the first common type of procedure is a sleeve gastrectomy. So if you have a look at the picture again, so because we're going to remove a portion of the stomach, you lose some of the absorption site of the stomach, but you do still retain all of the small intestine. Next slide. Then you've got the gastric bypass, which again, if you have a look at the diagram, so you have a remainder of a small stomach pouch, and you've got, you bypass the duodenum. So the stomach size absorption is significantly reduced, and you also don't have access to the duodenum, which is that unused portion of the small intestine. Next slide. So what does that mean for, what effects will these have on absorption? So for the sleeve gastrectomy, you've got a reduced gastric volume, which in turn increases the pH, so the acidity in the stomach, and it also accelerates gastric emptying. So your medication is going to go through your GI tract a bit more quicker. For gastric bypass, again, you've got the reduced gastric volume, which in turn increases the gastric pH, so less acidity. You've got the shorter intestinal transit time. So again, it's got a shorter length to go through the transport of the medication, and you've got a decreased surface area absorption. Next slide. So what does that mean? So will my body still be able to absorb medications? So it's not always easy. It depends on, we review your medications, and it depends on the surgery, it depends on the medication. It very much is on an individual basis. With a lot of medications, it can be measured in most cases. So if you think about what a lot of patients are on medications for, so for example, blood pressure, after your surgery, you can still continue to monitor your blood pressure and we'll know exactly how much you're absorbing. If, for example, your blood pressure is not being well controlled, then you may not be absorbing much, and then you can increase it. Similarly, so with a lot of medications, you can measure it in these cases. So that's still a good thing. So it's not a problem for most medications. We also have lots of books and resources and experience to think about how medications are absorbed and think about how the surgery will affect this. So before a drug even is approved for patient consumption, the manufacturer has to study where exactly the drug is absorbed, where exactly it's metabolized, where exactly it's distributed. So we have a good idea for majority of medications, exactly where it's absorbed, distributed, and metabolized. And so we know this for what it's like with patients, and then we can estimate what it would be like for when you have this altered GI tract. And so all in all, the ability to absorb also improves over time. Considerations need to be made. So we don't want to, after your surgery, you shouldn't be on any MR or XL preparation. So what that means is modified release or delayed release preparations. This is because the shorter intestinal length after gastric bypass can make these kind of preparations less effective, because the formulations and the way that they were supposed to be made is that they're intended to be absorbed over 12 to 24 hours, so a longer period of time. And the medicines may pass through before absorption is complete. So the same principle applies to enteric coated tablets as well. So if you're on those kind of tablets, we switch to immediate release tablets. And this means that you may need to take them a bit more often than you would have, for example, with the delayed release preparations. Another thing to take into consideration is the size of the tablet. So after the surgery, the opening produced by the Roux-en-Y surgery is around 1.5 centimeters wide. So that's the size of a 5p coin. So if you think about your tablets, quite a lot of tablets are bigger than this and cannot go through so easily. So that's when we need to kind of consider alternatives. Next slide, please, Stevie. So we review your medications and advise what can safely be crushed. Using different formulations can help reduce these issues associated with the anatomical changes because they are more rapidly absorbed. So liquid formulations, you don't need to kind of wait for them to be broken down in the GI tract in order for them to be absorbed. They're already one step closer, as are, for example, soluble tablets. Crushing, we'll have a look at what we can crush, make sure that it's safe to crush. With capsules, we normally recommend that you open up the capsules and disperse the contents in water before taking them. And there's also other routes of administration. So things like patches, where they don't need to, they go straight into the systemic circulation. Next slide, please, Stevie. So liquid formulations are rarely required anymore. That's because quite often we can crush, we can say with experience that by crushing tablets and dissolving them, you're going to get a very similar effect. We can sometimes switch to liquid formulations. That's because after your surgery, your diet is, you're on a liquid diet for roughly about 3 weeks. And obviously, depending on your tablets, again, this is all kind of very much an individual basis. We review your medications individually, and for what we may recommend for one patient may not be the same for another patient. So normally we can switch sometimes, depending on the type of tablet, we can switch it to a liquid form, switch it back to the normal tablets when they're able to tolerate these. We, again, always go for sugar-free liquids to avoid dumping syndrome. So I'm sure Chris, the dietitian, will have spoken to you a bit more about the dumping syndrome, but this is when the sugar enters the gut too quickly and it can lead to a lot of adverse effects. With the large volumes of liquid, again, it's quite a lot to tolerate, so we advise to slip slowly. Next slide, please, Stevie. So I mentioned at the beginning that when after these surgeries, you be put on supplements. So after these bariatric surgeries, patients are prone to deficiencies of the soluble vitamins, such as vitamin A, D, E, and K, and calcium. They also have an increased risk of anemia due to inadequate amounts of iron, vitamin B12, and folate. And because of these deficits, all bariatric patients, we advise that they should take a multi-daily vitamin, calcium supplements, and additional supplements with iron and vitamin B12. So I'll go through the reasons behind this a little bit if we think about it anatomically. So making the stomach smaller through bariatric surgery decreases the gastric acid production, which is needed in order to help absorb calcium. So because you've got less of it, you're not going to absorb as much calcium, and this in turn increases your risk of osteoporosis. So we counteract this by advising you to take calcium supplements. Iron, so the duodenum, so that bypass small intestine that we saw in the earlier diagram, is the primary site for absorption for iron. And obviously when you have a gastric bypass surgery, it's bypassed. Alongside, also similar to calcium, you need gastric acid to help absorb the iron. So this lacks. So again, we recommend that depending on patients will differ, and depending on other risk factors will advise you to take iron, whether you need to take an increased dose or a smaller dose. Vitamin B12 absorption requires intrinsic factor, which is produced in the bypass part of the stomach, as well as, again, the decreased gastric acid, which is required to help absorb the vitamin B12. The combination of this results in that you need to take lifelong vitamin B12 injections to help prevent vitamin B12 deficiency and anemia. Next slide, Stevie. So post-operatively, after your surgery, patients undergoing bariatric surgery are at high risk of developing venous thromboembolism. So depending on other risk factors as well, we start you on a blood thinner just after your surgery. So the one that we tend to use at Salford is tinzaparin injections. So these are blood thinner subcutaneous injections that we normally ask the patient to inject themselves, and the exact dose and how long you take it for depends on the patient. So the surgeon normally decides, depending on the patient's risk factors, exactly how long the patient needs to take it for. Pain control, again, we normally, obviously, after such invasive surgery, we normally I guess it's not as invasive, it's laparoscopic, isn't it? But you get post-op acute pain, and we normally give liquid paracetamol and codeine tablets on discharge. Lansoprazole fast tabs. So to prevent ulcer prophylaxis, anti-acid medications are prescribed to prevent ulcers developing at the point of where the surgeons joined up the two, has done the anastomosis, so at the joining of the surgery. To prevent an ulcer from happening there, we give lansoprazole tablets. So we normally recommend high dose lansoprazole for the first 6 months, and then after that, just we advise you to continue taking this anti-acid medication for another 18 months, but not at such a high dose. And then 2 to 4 weeks post-op, we start you on the vitamin supplements, the calcium supplements, and the iron tablets if that's appropriate. And in terms of, so obviously normally we'd recommend that we instruct patients usually to resume most of their preoperative medication. So whatever they were taking before their surgery, we advise them to continue taking after their surgery. And if we need to change the formulation of them, we will do that at that point. Some will also stop temporarily. So those who are on diabetic medications, they'll need to continue monitoring their blood sugars. Sometimes some patients, their blood sugars drop very quickly after surgery, and they'll need less of the diabetic medications. Normally we'll advise when the patients are on a liquid diet to stop their oral anti-diabetic medications, but the diabetes specialist nurses will be in touch with the MDT, and they'll advise on this as well. Blood pressure tablets as well. Normally, typically, the dose can reduce after surgery as you start to lose the weight and your blood pressure control improves. Then you need to maybe stop taking less of them. That's it. So next slide. So thanks, everyone. I can see there's quite a lot of questions already. We'll try and answer them.